The goal of this presentation is to explain the supraspinatus anatomy. The supraspinatus originates from the supraspinous fossa. It courses through the subacromial space and inserts in the common rotator cuff insertion with most fibres onto the superior facet of the greater tubercle. The supraspinatus has two muscle bellies. Here you can see a posterior-superior view of the left shoulder. The full supraspinatus can be seen. The spine of the scapula has been cut away. The image shows the two distinct muscle bellies of the supraspinatus. The anterior muscle belly, with larger muscle size, is essentially fusiform, originating entirely from supraspinatus fossa. The posterior muscle belly is a smaller unipennate muscle that has no intramuscular tendon and originates mostly from the scapular spine and glenoid neck. Here you can see a schematic representation that shows the anterior and posterior musculotendinous anatomy of supraspinatus. It shows that the anterior supraspinatus muscle belly has a long intramuscular aponeurosis. The posterior muscle belly does not have this intramuscular aponeurosis. One can conclude that the anterior supraspinatus belly is responsible for the major part of the contraction forces because of the larger muscle size, the presence of the intramuscular aponeurosis, the smaller insertion, and the bipennate muscle architecture. Based on its architecture, the posterior muscle belly is not suited to heavy loading. It's designed as a feed-forward mechanism. It tightens the glenohumeral capsule prior to actively abducting the arm to prevent capsular impingement. Research in tensile stress of the supraspinatus in 0 to 30 degrees and 60 degrees of active abduction shows that the highest peak stress is near the cortex of the humeral head. We can see that with higher abduction levels, the forces will concentrate around one specific point, the column anatomicum, the spot that is being loaded the most. This frontal view of the left shoulder shows the subacromial anatomy in detail. The glenohumeral labrum attached to the glenoid cavity, the glenohumeral capsule originating on the glenoid cavity and labrum and inserting at the column anatomicum, the supraspinatus muscle, the supraspinatus tendon inserting to the superior facet of the greater tubercle, the subacromial subdeltoid bursa, and the AC joint between the acromion and clavicle. The supraspinatus tendon around the column anatomicum, indicated here with an oval shape, is loaded the most. It also has more friction on the tip of the acromion than other tendon parts. It might seem logical that the part of the tendon around the column anatomicum is avascular due to the compressive and friction forces of the acromion. And due to that fact, this part is being loaded the most in higher levels of abduction. This avascular zone will increase with aging. So to summarise, the supraspinatus tendon area around the column anatomicum carries the highest load, ensures the most friction, has the poorest vascularisation, and therefore clinically we see the highest risk there. The black pin in the tendon is indicating a large supraspinatus tendon tear. The column anatomicum is therefore a very important zone to focus on when scanning the supraspinatus tendon. The last part of the supraspinatus has a clear interconnection with the glenohumeral capsule fibres. The relevance for clinical musculoskeletal ultrasound is that there is a high risk that in the case of a supraspinatus problem, the capsule will also be affected. Please also note in the image that the posterior border of the insertion of the supraspinatus is overlapped by the anterior border of the infraspinatus tendon. All rotator cuff tendons mingle and share one common insertion. When assessing certain parts of this common insertion of the rotator cuff, for example, the part visualised in this image, one cannot say whether the tear is in the supraspinatus, the infraspinatus, or in the common zone. So be sure to avoid hard statements if a pathology is present in such an overlapping zone. Here you can see the anterior view of the right shoulder. The rotator cuff interval, indicated with the arrow, is a spot in the anterior superior shoulder that has no rotator cuff tendon presence. The borders of the rotator cuff interval are made by the subscapularis and the supraspinatus. The only structures present in the rotator cuff interval are the long head of the biceps and the superoglenohumeral ligament, the coracohumeral ligament, and the glenohumeral capsule. The relevance for ultrasound: if scanning the supraspinatus quite medially, you might see a hypoechoic zone containing a hyperechoic oval structure. This hypoechoic zone is the rotator cuff interval. It is hypoechoic due to the lack of tendon fibres. The hyperechoic oval shape in the rotator cuff interval is the long head of the biceps.